Hello everyone. Let's start oral cavity and salivary glands disorder. So the first topic is leukoplakia. In this topic we can see that it has white patch or plaque which is not less than 5 mm in diameter. It can't be removed by rubbing. It cannot be classified as any other diagnosable disease. It can undergo malignant transformation. So now coming to the sites. In oral cavity, it is present in the buccal mucosa, floor of the mouth, tongue, palate, and gingiva. In number, it may be single or it may be multiple. In appearance, it has a sharply defined borders. So now coming to erythroplakia, it is less common. It is red velvety area within the oral cavity. It has atypical epithelium. The most important factor is it has increased risk of malignant transformation than leukoplakia. The next one is splect leukoerythroplakia. It is a combination of both leukoplakia and erythroplakia. It is seen both in adults, age of between 40 to 70 years, coming to ratio between male and female, 2:1 is the ratio. The etiology of this is it is multifactorial origin with the use of the tobacco. Microscopic study shows that in leukoplakia, surface stratified squamous epithelium, it ranges from hyperkeratosis and acanthosis to variable degree of dysplastic changes. In subepithelial origin, it has inflammatory infiltrate of lymphocytes and macrophages. Microscopic studies of erythroplakia shows that the epithelium, it has erosions with dysplasia, carcinoma in situ. In subepithelial, it has intense inflammatory reactions and vascular dilations for reddish clinical appearance. Now, the next is hairy leukoplakia. It is a distinctive oral lesions in immunocompromised patients. 80% of hairy leukoplakia is of HIV positive patients, and of 20% it is of other reasons. The main etiology of this hairy leukoplakia is Epstein-Barr virus infection, and the site of this is lateral edges or lateral borders of the tongue. The morphology of this hairy leukoplakia is in gross, it has white confluent patches of fluffy, which means hairy thickening. In microscopic study, it shows hyperkeratosis and acanthosis with balloon cells in the upper spinous layer. The next is squamous cell carcinoma. Squamous cell carcinoma of oral cancer, majority of the oral cancer is squamous cell carcinoma. The important site is tongue, then lip. In India, the most common site is buccal mucosa compared to anterior tongue. The risk factor of this squamous cell carcinoma of oral cavity is first the tobacco products and the smoking. The tobacco products contains carcinogens which may be initiators or promoters. The tobacco can be of two types. It may be of smoking tobacco or smokeless tobacco. In smokeless tobacco, it is of betel quid or pan. The next cause may be alcohol consumption. And others. In other factors, there may be radiation, welding, metal refining, chronic irritations of mucosa, vitamin A deficiency, and poor nutrition. One side note, in oral carcinomas, it has both types of HPV viruses, that is high risk HPV types 16 and 18 and low risk HPV types 6 and 18 may be positive in oral carcinomas. Coming to pathogenesis of squamous cell carcinoma, first is inactivation of a p63 gene, that is the conversion of a stratified squamous epithelium to hyperplasia or hyperkeratosis. Next, after inactivation of p16 gene, it is the mutation of the p53 tumor suppressor gene. And later, amplification and overexpression of cyclin D1 gene. The next carcinoma is verrucous carcinoma. Varicose carcinoma is the variant of well-differentiated squamous cell carcinoma. Most commonly, it is seen in buccal mucosa and lower gingiva. It mainly caused by tobacco, chewing, snuff clipping, and HPV infections. Coming to its morphological features, it is large, fungating, soft and papillary growth. In microscopic studies, it is seen as hyperkeratosis, acanthosis, benign appearing papillomatous, and repex swollen. Coming to the various features microscopical, we can see that in squamous cell carcinoma, in H&E staining, we can see the epithelial pearls, which are the distinctive features of this carcinoma. In diagrammatic features also we can see the epithelial keratin pulse, and there is presence of intercellular bridges. In varus carcinoma, which is the important type of squamous cell carcinoma, we can see that there is the presence of exophytic tumors, well-differentiated squamous cells, and the voluminous red peaks which are descending downwards. Now the next main important topic is salivary gland neoplasms. So it can be differentiated into two parts, that is benign and malignant. In benign, we can see that the most common is pleomorphic adenoma, Warthin tumors, oncocytoma, and basal cell adenoma. In malignant, we can see mucoepidermoid carcinoma, adenocarcinoma, acinic cell carcinoma, adenoid cystic carcinoma, and malignant mixed carcinoma. Coming to pleomorphic adenoma, it is the most commonly seen in parotid. It is a combination of both epithelial and stromal, hence it is known as mixed tumors. It has variable cell type in this lesion. It is predominantly seen in females than males. It is rarely seen in minor salivary glands. It is usually present in the superficial lobe of the parotid gland. It is known as mixed tumors due to the reason that it is comprised of both epithelial components and mesenchymal components, myoepithelial or ductal reversal of cell origin. The main important part is the chromosomal rearrangements in PLAG1 gene. The main feature of this is this increases the expansion of gene which helps in cell growth. Coming to the feature of this carcinoma, this feature is it has well circumscribed or encapsulated, but the capsulated may be pseudopodia, that it is not wholly covered by the capsule. It has some appearance coming from it. Coming to the cut surface of this salivary gland tumor is on cutting surface we can see that gray white with myxoid and blue glistening translucent chondroid structures. Coming to clinical feature of this tumor is it is painless, slow growing, mobile, discrete tumors in parotid and submandibular glands. The next important tumor is Warthin's tumor. It is exclusively seen in the parotid glands. It is also known as papillary cystadenoma lymphatomosum. It is benign and second most after pleomorphic adenoma. It is most commonly seen in males. The important factor of this tumor is smokers have 8 times more risk factor compared to the normal individuals. Coming to the morphology of this Warthin's tumor is that shape, it may be oval, encapsulated. Size, it may be around 2 to 5 centimeters. It mainly seen in the superficial parotid glands. On cut section, we can see that it has pale gray tumor appearance. Note of this tumor, it is 10% multifocal, 10% bilateral. It never involves facial nerves. On microscopic study, we can see that Warthin, it is comprised of both epithelial and lymphoid elements. In this, we can see the presence of cystic spaces. In cystic spaces, this is covered by 2 layers, that is surface superficial layers of columnar cells with abundant finely granular eosinophilic cytoplasm. In this, it has a particular type of cells known as oncocytes. These oncocytes are abundant mitochondria which gives the granular appearance in this eosinophilic cytoplasm. The second layer, it is mainly of cuboidal to polygonal cells. The next, it has presence of lymphoid tissues along with these cystic spaces. These lymphoid tissues generally resembles to the normal lymph nodes. Coming to microscopic photo of this Warthin tumors, we can see the cystic spaces lined by double layers of neoplastic cells, and there is presence of lymphoid stroma with prominent germinal centers, which generally represents like normal lymph node. Now, the next tumor is mucoepidermoid carcinoma. It is the most common malignant tumor. Remember, it is not benign, it is malignant. It is the primary malignant tumor of the salivary glands. It is primarily seen in the children. 15% of all the tumors, 60 to 70% in the parotid gland. The most important, it is seen in the parotid glands compared to submandibular or other any minor salivary glands. The main etiology of this is it is a distinctive balance, that is 19 to 19 is 11 is to 19 to Q21 is to P15 chromosomal translocation can be seen in this type of carcinoma, which leads to fusion gene composed of portions of CRTC1 and MAML2 genes. The main part of this is action of the Notch pathway. On morphological features, we can see that in gross section, it has 8 cm in diameter. It appears as a circumscribed. On cut section, we can see as it is pale and gray-white appearance. On microscopic features, we can see that it is a mixture of squamous cells, mucus secreting cells, and intermediate cells. It is arranged in cords, sheets, and cystic structures. The intermediate cells, it is squamous features with small to large mucus-filled vacuoles. The important note, most common malignant tumor of minor salivary glands is adenoid cystic carcinoma. Above we have seen that the most of all are major salivary gland, that is a parotid, which comprises of 60 to 70%. So here the minor salivary gland, which is most common malignant tumor can be seen, is adenoid cystic carcinoma. The main important features of this is it has a cribriform pattern and Swiss cheese appearance. The tumor that spreads perineurally are adenoid cystic carcinoma, adenocarcinoma of prostate, cholangiocarcinoma, carcinoma of the gallbladder, carcinoma of the pancreas. Now, we can check your understanding by answering these questions. Which of the following is the most common cause of the oral candidiasis? Option A, Cryptococcus mutans, Candida albicans, herpes simplex virus, Epstein-Barr virus. A 45-year-old smoker presents with painless white patch on the buccal mucosa that can't be scraped off. Please comment the diagnosis. The options are oral thrush, leukoplakia, lichen planus, squamous cell carcinoma. Most common benign tumor of salivary glands. Option A, mucoepidermoid carcinoma, pleomorphic adenoma, Warthin tumors, adenoid cystic carcinoma. Which salivary gland is the most commonly affected by ciliolithiasis, that is salivary stones? Parotid gland, submandibular gland, sublingual gland, minor salivary gland. Next, a patient presents with painful ulcer on tongue with grayish base and erythematous borders. Diagnosis can be herpes simplex ulcer, aphthous ulcer, squamous cell carcinoma, and syphilitic canker. So, please answer these MCQs and comment the correct answer in the comment section below. The answers to these 5 questions will be given in the upcoming next video. Thank you.